There you go. There. Hey, Hal, can you hear us now?
All right.
Thank you. It was on before, we did it test. And then, so I don't know what everybody.
I hope you can all hear me. I'm Joe Uberti. I'm the head of the Cancer Center at Hermanos. And I spend much of my time doing stem cell transplants and CAR T cell therapy for myeloma and involved in a lot of the treatments that are now available for patients with myeloma. So I'd like to just kind of go over some things and maybe just open it up to questions after that. As you know, the therapy for myeloma has really expanded. Every year we have better therapy. So the good news is that we have a lot of different therapies for myeloma. Get treated again and again and again. The not so good news is here for it. So, but having said that, people live a very long time with myeloma. We can control the disease. And what we're trying to do more than anything is to keep the disease under control until we do find a cure. Are we close to finding a cure? I'm not sure yet. And I'm not sure how close we are, but we're certainly getting better every year in terms of treatment for myeloma. And because so much of the therapy changes and attacks the myeloma by different ways, it's a way of getting effective therapy, even though you failed a number of therapies. Now, unfortunately, what that means for most of our patients that are on therapy forever. So we try to give them breaks of therapy just to recover from things, but many of our patients are on continuous therapy for a long time. It does keep the myeloma under control. We find ways to avoid some of the side effects of therapy when we're in long-term treatment options for our patients. But we have patients out 10, 15, 20 years now, and that's not as unusual as any unusual longevity anymore. So that's where we are with myeloma. So I focus in on using CAR T cells for myeloma, using transplant for myeloma, both of which have still proven to be very effective as various treatment options for myeloma. So there are now two commercially, let me just go through some of the things. There are now two commercially available CAR T cells, I think since we last spoke, that we can use in patients who failed a number of therapies for multiple myeloma. So what CAR T cells are really a unique thing that's been used in a number of different diseases. And what we do is we take your cells out of your body, your lymphocytes, and infect them with a virus that targets the myeloma cell. And it's very effective. It takes about 4 to 6 weeks to make these cells. They insert a virus into these cells and it gets inserted in their DNA of the cells. And these cells are very good at binding to myeloma cells and killing off myeloma cells. And it's been very effective. Either of these two therapies are very effective. They could put patients into remission. They can have remissions that last as long as 3 or 4 years, I've seen in some of my patients. And these are very deep remissions. We don't think yet it's a cure because most of our patients have relapsed, but there are a few patients I've seen who are out 3 years with no detectable site of disease in their entire body. So that's pretty remarkable. And these are patients who've already failed 5 or 6 therapies, patients who've gone through transplant. So it does work extremely well in some patients, not in all patients, but in some patients. It does require us to harvest your cells. It does require us to have your cells manufactured at a facility, which takes about 4 to 6 weeks. It does require a hospitalization, but it can be very effective. You know, there's another bifunctional antibody called teclistamab that also targets the same thing as the CAR T cells do. So what these two agents do is target a surface protein on your myeloma cells. So we can often use them one after another, even though they target the same target. They do work in different mechanisms, and even if you failed one, you can go on to be successfully treated with a different one. So these are the two things that really come up most recently in terms of treating patients with myeloma. And there's other investigational therapies that are available to us, other types of CAR T cells that now target different molecules on the myeloma cells, other types of bifunctional antibodies, such as teclistamab, that are also effective in being looked at in investigational trials. So the field of myeloma is progressing rapidly. Again, although we don't have a cure, we're getting closer every year. So that's where actually anxiously anticipation. What is the cure? When are we going to be able to cure patients with myeloma? because we're getting pretty darn close right now. Not quite there yet, but we're pretty darn close. There's a lot of great treatment that doesn't involve CAR T cells, that doesn't involve transplant, and those are also available. You know, right now we do about 130 transplants for multiple myeloma a year. It's the most common disease transplants are done for in our center, around the country, and around the world still. So although it seems to be a hard treatment, it's really not that hard. Compared to the cost of everything else, it's fairly cheap therapy nowadays, and people do well with it. So it is part of our standard treatment for most of our patients with multiple myeloma. So I've been doing transplant now for 35 years, I think, maybe even more, just seems like forever. So we've had a lot of experience taking care of patients with myeloma. We've done a lot of transplants, we've done a lot of CAR T cells. I think we're the only center in the state of Michigan that has all the CAR T cells for multiple myeloma right now. And we do it, we admitted 2 patients yesterday for it. So it's routinely done for our patient population. So we do a lot of things for myeloma that we've never been able to do before right now, which is really good for all of our patients with myeloma. So I would like to open it up to questions or concerns or other things we can talk about. Allow us to Tiger baseball game.
So if you're on the Zoom and you have a question, please just either unmute and ask it, or put it in the chat and I'll read it, or we'll or raise your hand. Keep one of those little Zoom raise your hand things. And here, those of you that are here, but please ask questions.
So why is CAR T now used like after a few other instead of earlier on in treatment?
So that's the way the studies work. You hadn't failed 4 therapies before you could be eligible. And one of those therapies has to include daratumumab or a drug like that.
Okay.
So that's how the FDA has approved the drug. Now, unfortunately, it cost us $500,000 to buy CAR T cells. So it's pretty expensive, and we have to follow the FDA guidelines, which says before you can get CAR T cells, you have to fail 4 therapies. So we can't do it, or else they won't pay us for it. We don't like losing $500,000. So,
But is there studies that show that it works effectively as first round treatment?
so that hasn't been looked at yet. So the companies that are making CAR T cells are kind of trying to move it up the line, you know, say after 3 failed therapies or 2 failed therapies. So that's what they're trying to do right now with CAR T cells. But again, it's only FDA approved if you have after failing 4 therapies. As is the new agent teclistamab, get off the shelf. It's a bifunctional antibody. But even for that one, you to take that one. That's an IV infusion. You get once a week. Again, that's far down the line from see them initially. But those they're available, and they make they're given based on new.
Hal's raising his hand.
Okay.
Go ahead, Hal.
Does Medicare cover the cost of a CAR T cell transplant?
So that's a tough question. Sometimes they do, sometimes you know, but some of the other. Obviously, one of the difficulties is to get Medicare to reimburse us for it. We have had trouble getting full reimbursement for the CAR T cells for myeloma. So we're working on it. We usually are able to get it, but it does give us a pause because it's such a big outlay for us to buy the cells. So the answer is yes, but we have to work at it to get reimbursement for CAR T cells. You know, all the drugs and all the therapies we're getting are become so expensive that it is somewhat discouraging how much these cost. Teclistamab, the other antibody, the bifunctional antibody that's been approved for myeloma, if you take it for a year, it's $640,000. So it's getting up there in price. I mean, obviously, if you're a patient, you're going to want to take it. So
Right.
we want to make sure we get paid for it as well.
Are you familiar with CAR T cells made in Israel?
Say it again.
They're making CAR T cells now in Israel. Are you aware of that?
Some centers do make their own CAR T cells. So there's places in the US that make their own CAR T cells. So it's thought that to make a CAR T cell right now, it costs about $15,000 to $20,000. But the companies that, you know, got the FDA approval are charging $500,000. So some places are looking to try to make their own CAR T cells because of such a cost advantage. It's not that easy for a lot of different reasons, but there are people doing that. Israel certainly has done it.
Yes.
There's centers in the US who have done it as well. You know, they're not FDA approved when you do it like that. So it's more of a investigational trial, but you usually don't have to pay for the CAR T cells when you're on those sort of trials. But they don't have probably the amount of data that tells us how effective they are right now.
Dr. Uberti, do you know of any research trials in Michigan where you take teclistamab after failing 2 rounds of therapies?
Don't think so. I don't know that for certain, though. I can check with you, but I think the FDA approved indication is after 4 lines of therapy. So, you know, the studies that gained FDA approval only took the worst patients. That's how they do these trials. And that's the way the trial was set up that got FDA approval. You have to fail 4 lines of therapy. So there may be some trials to look at using it sooner. That may be the case. I don't know of any offhand. There are trials soon to open up to look at teclistamab after transplant, I think, as well. But that's not open yet at our center.
Anybody else? Please ask questions. This is an opportune time.
So it's a tough thing for patients, I think. They want to say, well, if this is such good therapy, why don't we use it sooner? And our hands are tied by the FDA approval process because it costs so much to get these drugs. If I try to give it to one of my patients who's failed 3 therapies, they're going to charge me $500,000 and they won't reimburse me.
Are you finding that people are going to Israel to get this therapy?
I don't know that for certain. It's possible they could be. People do go to other centers if they have the ability to get CAR T cells that are homemade CAR T cells, but those are all investigational trials. So, you know, if insurance pays for it, you know, you should get it if you need it. Certainly, you have to go by the 4 things that you failed before you can get them.
I have a question.
Sure.
We were here last time with a doctor, I believe in New York, that we sat and talked with. My nephew would stand over there, talk with them. And he mentioned that they were going to do a research whether multiple myeloma was a generic form of cancer that goes in the male families. Has there been anything noticed on that?
You know, I don't know of anything recently. Certainly, we do feel some cancers are genetically influenced by your family, and we do find families who have multiple family members who have myeloma. How to define that and how to treat that. The treatment is really similar to what we do with myeloma that's just sporadic we see in our patients. So there probably is some genetic component to it. What that is exactly is difficult to say yet.
Well, my brother passed away from non-Hodgkin's lymphoma. And then my nephew has it, and we're kind of concerned about the male from their side.
So what you can do is they do have genetic counselors available for patients, families who have a high incidence of cancer that you can see. And they could do certain testing on the family members to see if they have some of the predisposing genetic mutations that indicate you may be more susceptible to types of cancers.
And what would that be done?
There are genetic counseling centers. We have one at our campus. There's one at U of M. There's one at Henry Ford. They look at patients who have a lot of family members with cancer. And if you meet certain criteria, they'll go forward with testing on the DNA of patients or people in your family who have the disease and people who haven't had this.
All right, thank you.
I have a question. My husband had a physical in December, and I spoke to the doctor a few days ago, and he said there was no red flag, that his hemoglobin or proteins, nothing was off. Is it possible that it could come on that quickly?
He probably had it at that time, but it just wasn't showing any of the markers that we normally use to look for it.
Is it that
No.
fast? I mean,
Well, it was probably there for a while. It takes a while for the cancer to become symptomatic in patients. We always have a case. Let me just give you an example. So many of our multiple myeloma patients come see us and saying, what happened? I had back pain. My doctor saw me for it. He just gave me physical therapy. He sent me to a chiropractor. So there's a delay in getting the symptoms identified as being cancerous. And it's just what happens. You know, there's no way, if you don't have any blood markers that show it's a myeloma, you know, it doesn't pop up on some of the x-rays very early in the disease course, even though it's there. So sometimes there's no way to tell somebody has multiple myeloma, even though we know it's there. So there's an interval period before when the cancer starts and when you become symptomatic or you show signs of the disease. And there's no way to find that before we see those signs, even though it takes a while for it to build up. So everybody, by the time we see them, I suspect everybody's had myeloma for a year or so. At least. Yeah. But you know, although that's not good, it probably doesn't change how we would treat you. Because even when we pick it up early, before you're symptomatic, it's controversial whether to treat it at that point. And sometimes people say you have to wait till it becomes symptomatic, because not everybody who has early myeloma goes on to develop this full-blown disease. So you don't want to over-treat some patients who need it. And sometimes it's hard to distinguish between those patients. So we have diseases called MGUS and smoldering myeloma that are kind of precursors for multiple myeloma that we see in patients. So they have very early signs, and sometimes we don't treat them at all because sometimes they don't want to develop multiple myeloma. So we're looking at markers that we can identify to tell us who to treat at those early stages and who not to treat. Anybody on the video conference?
Yeah, anybody else have a question?
There's a hand.
Oh, yeah.
Somewhat related to what we just discussed, after a first remission and then going into a first relapse, how long do doctors wait? Because I've seen different opinions about that. Some doctors are saying, you know, you should get a PET scan and do different types of imaging that didn't used to be done, MRIs and so on, because they say that the typical blood markers don't show up sometimes. And then other doctors are saying, no, you should just wait till the, if you have the lambda kappa ratio, and if you look at that, if one of your types of myeloma is either lambda or kappa, you just look at that and you look at the M protein and you wait till those get high and abnormal. So I wondered if doctors are treating before as they see the cycle go up and into the higher normal.
Well, yes. So that's somewhat of a complicated question you've asked. So some people have disease that's only in the bones and don't have blood markers that signify their disease. Some people have disease that's only in their blood and don't have any bone problems. So you try to follow them differently. So the ones who have disease in the bone and not in the bloodstream, the only way you can probably manage see how well they're progressing or how well they're in remission is by doing the scans, such as PET CT scans, CAT scans, MRIs. And some people who have markers in the blood, usually the blood is a pretty sensitive indicator of when their myeloma comes back. Now, when to start treatment really depends on how quickly and how fast things are moving. If your lambda light chain, let's just say, goes from 2 to 4, which is a little bit of an elevation in 2 or 3 months, you probably wouldn't treat that. If it goes from 4 to 100 in a couple of months, then you probably start treating because the disease is progressing a bit more rapidly than you'd like. And you want to make sure that nothing happens to that patient. So as an example, if your light chain goes up, you can go into kidney failure. So you have to judge how quickly that light chain is going up and how close it is to causing something more serious to happen, such as kidney failure. So it has to go by the patient. It has to go by the rate at which things are going up. And that's usually makes the decision for us based on those things. Plus the patients are symptomatic. If you have a lot of bony disease and you tell me you have pain in an area and we do scans and shows the pain's from myeloma, then that's an indication to treat. If you become more anemic from your myeloma, that's an indication to treat. So I think we have to use all those factors in our judgment to decide when we start retreating patients. You know, you have to look at what's getting worse, how quickly it's getting worse, and how symptomatic the patient is. And then you have to weigh into what's the next therapy. There's a lot of different choices. So you try to pick a therapy that doesn't cause any toxicity that the patient may already have. So an example, if you have a lot of peripheral neuropathy, you don't want to pick a therapy that's going to add to that. So you want to try to pick one that doesn't add to the peripheral neuropathy. So, you know, it's a judgment call. It takes a little bit of art to figure out when to start treatment and what to treat patients with. Did that answer your question? I hope. Maybe
Yes.
not.
Yes, it did. Thank you very much.
And there are a lot of options available now for treating patients. There's just a ton of different therapies. There's a ton of different combinations that we can use. So there's a lot of options available. And some of it is dictated by some of the genetics you have that we find by fish and cytogenetics. Sometimes that tells us one therapy may be better than another therapy. So we try to take all those into account when we're trying to figure out how to treat the patient with the next steps. So the other thing that's become, I think there's another question there.
Okay, I will unmute now. Yeah, you gotta unmute, Cal.
Okay. If you've had a successful stem cell transplant and you've had a good partial response to your trailing therapy of the Revlimid, and you haven't had a relapse, are you considered in remission if you don't have symptoms?
No, to be in remission, you have to have, all your markers have to be negative and your bone marrow has to be negative, and there can't be any new lesions in the scans we do. So we have a formal way of defining remission. You fit all that criteria. But sometimes in my patients, I don't want to know if they're in remission as long as things are under control and they're not having any symptoms. So if you have an elevated kappa light chain, let's just say, it hasn't gone down to 0, but you're doing okay, we don't worry too much about that. It's, let's say after a transplant and you're on Revlimid, you're not in remission as long as we have any measurable disease. But as long as your disease is not progressing, probably wouldn't do anything differently. So a remission is by the formal definition, it has to be negative markers, negative bone marrow, no new bone lesions. So the new term we now use is minimal residual disease. And it's abbreviated MRD. So that's what we look at in terms of patients with any type of cancer. And in multiple myeloma, as an example, we have new ways to look at what's called minimal residual disease. So if I do a bone marrow biopsy on somebody with multiple myeloma right now, I could find 1 in a million cells that are myeloma. That's how sensitive our testing is. So that's one of the new definitions we use for MRD negative. So that's a very sophisticated way to look at myeloma cells. And that's what we call MRD negative. And you can set at whatever you want. It can be 10 to the -5, that is 1 cell in 100,000 is a myeloma cell, or 1 cell in a million is a myeloma cell. So obviously, if we want to cure you, we want to see no cells in your body that are myeloma. So we think that one way to look at maybe getting if you can't cells so MRD is right now in all cancers, especially multiple myeloma, because we have new ways of looking. I mean, it's great if we could put everybody MRD negative, and we think they live longer, and there's a long time before the myeloma comes back, but sometimes that's hard to achieve.
There seems to be a pretty wide range of people who respond and don't have a relapse. And is there any way to predict when patients might have a relapse? Is there anything you can do as a patient to prevent relapse?
Well, what we usually do for most of our patients, I think many patients are on maintenance therapy to prevent relapse. And So after bone marrow transplant, as an example, people usually go on Revlimid or a combination of Revlimid and Velcade, or sometimes daratumumab to prevent relapse. So that's probably the best example I can give of patients on light therapy that prevents relapse. When people go through standard chemotherapy, sometimes we put patients on Revlimid at a low dose to prevent relapse. So there is things we do to try to prevent relapse, and that's called maintenance therapy. But when we do maintenance therapy, we don't want to give you something that's going to cause symptoms. We want to find simple therapy that you could use. If it's oral therapy, for it. Maintenance therapy with Velcade given every 2 weeks. Sometimes we use Doxil or daratumumab that's given every 2 months as maintenance therapy. So there's different ways we try to use very simple therapy that doesn't cause side effects that keeps the myeloma away. It's fairly successful. It's not perfect, but it is a way we try to keep the myeloma under control. The goal is to not give you any side effects from the therapy. If I give you maintenance therapy, it makes your life miserable. I'm not doing much for you. But if I could find maintenance therapy that you could tolerate very well and keeps the myeloma well, then we've hit on something. So that's what we try to do with our maintenance therapy.
Thank you.
Hal, I saw your, yes, Hal?
I finally figured out how to unmute my mic. I think it was yesterday, new guidelines were put out about COVID vaccine, and for those over 65, if it's been at least 4 months, and if you're immunocompromised, if it's been over 2 months since you last had the bivalent vaccine, you should get another booster. What I'm wondering is, if you're in therapy, should you wait until you're in your off week to get the vaccine, or doesn't it matter?
So that's a good question. And what we tell our patients, if you can wait to be off therapy, it's better to try getting a vaccine then. However, if you're on therapy continuously, it's still better to try to get the vaccine. It might not be effective in those situations, because all the drugs we treat your myeloma with prevents your body from reacting to a vaccine, because it's the same kind of cell we're inhibiting. The myeloma cell is similar to the cell that responds to your vaccine. So that's the difficulty we have. But we always tell our patients, regardless of that, you should get vaccinated. So I think the new guidelines, which are a bit confusing to me yet, are recommending everybody get the bivalent COVID. So, and it's a problem. A lot of our patients don't respond to it, probably because of the therapy they're on. But it doesn't hurt really to get the vaccine, so we do recommend getting the vaccine, even if you're on therapy.
So what about without without therapy?
The vaccine or the
No, just success rate for myeloma not to come back without a therapy.
so I can give you the example with, I'm trying to think of a good example. So if you look at patients who got Revlimid after transplant versus patients who don't get Revlimid after transplant, they stay in remission about 3 to 4 years longer. So that's the best example I can think of. Now, it doesn't mean there's nothing else to try when the myeloma comes back. It's just going to stay under control longer with Revlimid as opposed to not being on Revlimid. So that's the easiest thing I can give you as an example. And it depends a lot where you started with and what you got and what the therapy is you're using in maintenance therapy.
Okay.
Again, go ahead. I'm sorry.
That's okay. Sorry. Another question about the booster. Is it the same makeup as this booster that we would have had, 6 months ago? The one that's formulated to work against Omicron?
But it's
variant?
called a bivalent booster right now. They may have a new one coming out. And I think the recommendation is to at least get the bivalent booster, which is the same one they've had for about a year and a half now. But I think there'll be a new one coming out. I think they said in the fall, and they're going to recommend that everybody gets that one too.
Thanks.
So if you got the booster in the fall, last fall, should patients, or should anybody actually be getting this the same shot again now?
No, I think what the recommendation is, I could be wrong about this, that wait for the next bivalent booster to come out. I think that's what they're recommending. Now, I could be wrong about that. I don't
Yeah,
have the stamp.
I got a call from the pharmacy that I got my bivalent one in September, and she said you're eligible for another
Are
one.
you?
Yeah,
That
that's
could
what
be the
she said.
case, yeah.
I haven't gone yet, but
Yeah.
she called me last week as soon as that new one came out.
Being a very proactive pharmacy. But they know more than I do. That may be the case. I don't remember exactly what the current guidelines on for revaccinating with COVID vaccines. But it's an ever-changing landscape, for better or worse,
That's for
things
sure.
change rapidly.
What kind of markers and indications would you label a fit like a therapy failed?
So usually we look, if there's markers in the blood, if it goes up over 25 to 50%, then we label that a failure. That's usually
So you're looking for growth.
yes. Yeah. I mean, from one day to the next, it may vary a little bit, but the trend is going up. And once it hits about the 25% mark and change, then we probably think it's time to change therapy.
Alan, I saw you, and Karen too.
Go ahead.
Do you know whether or not there has been any movement on getting venetoclax approved by the FDA? And will that possibly bring the price down?
Nothing has brought price down for drugs. I see my pharmacist friends at the end of the table here, but venetoclax is very effective in patients who have certain molecular markers in their bone marrow. So that's where it's used most. So if you have a specific translocation in your bone marrow, that tells us that you're going to be sensitive to the effect of venetoclax. So I don't think there's been trouble getting reimbursement for that, but you may have a different idea because all these drugs are very expensive and copays are astronomical. So
That's what worries me right now. A grant is paying for my copay, which is close to $800 a month for it. And I don't want to go off of it because I have the translocation and it has been working. So I just wondered if it would make a difference in anything if the FDA approves it. Insurance is paying for some of it, but it's, so far as I know, it's only FDA approved for lymphoma and leukemia.
you're absolutely right about that. But there are some drugs we use that don't require FDA approval and the insurance still pays for it. So, they'll probably continue to help you with the payment for that, I hope.
Me too.
We call that financial toxicity.
Thank you.
Times the worst toxicity we can have.
I hit the wrong one.
Are there still opportunities for Evusheld injections for immunocompromised patients?
We don't recommend that anymore because the Evusheld doesn't cover some of the new variants of COVID-19. So before, with the initial some of the COVID-19 species, it was effective, but we haven't given it in a long time. So we don't recommend patients get it. The COVID vaccine, the bivalent vaccine, is still the best thing for it right now. And there's an oral medication when we have it. There's Paxlovid, which is an oral medication. So when our patients get COVID, we do recommend they take the Paxlovid. I had COVID a few months ago and I took Paxlovid. So.
I remember when you had it. It was a couple of years ago.
I had it twice.
Oh, did you?
My third time, maybe the end of me. The second time was worse than the first time. Yeah.
Oh.
So somebody mentioned something I wanted to touch on a little bit. Somebody asked me if you could tell how aggressive your disease is. There are, maybe they talked about that just a bit. We could tell sometimes by doing sufficient cytogenetics on your sample from your bone marrow, how aggressive your disease may be. And there's different translocations and there's different mutations that tell us more aggressive disease or less aggressive disease. So that guides us sometime in how we treat patients. So that's an important risk factor we try to determine right at the time of your initial diagnosis. And sometimes you have the 11-14 translocation. That tells us you may respond to venetoclax. So that gives us another agent to use in the treatment of myeloma. So not many patients have that translocation, but when they do have it, certainly that gives us another opportunity to treat it. And as you said, venetoclax is working pretty well for you. So that's a good sign.
Is diet important when you're fighting this type of cancer?
No, I think diet's important just in a broad sense of things, but I think we just recommend to take a standard diet. I don't think there's any one diet that'll help any more than just keeping your nutrition up. So
Sugar?
it doesn't hurt. Sugar doesn't feed the cancer. I don't believe that has an effect on things. I mean, if you have to have diabetes along with things, then you have to worry about that, but not so much for the cancer. There's never been any proof that really increases cancer growth. So you're looking at your.
He didn't hear that.
I haven't had any sugar in 7 weeks, but I made them.
Well, I don't want to come to my family.
But I had a piece of it.
Nice.
But I had.
Don't tell your.
Yeah, I did.
So all the physicians we work with are doing their best, I think, to treat everybody as well as we can. And we appreciate your help with us. We appreciate you supporting us. And I think we really try to find ways to help everybody. So I think sometimes, we're hurried and we're in clinic and we're busy and you're late for appointments. We're late seeing you. And sometimes we just can't avoid that. So, but we do appreciate all your kindness and all the things we try to help you with.
I'm telling everybody, I'm having my chemo on Friday.
You're gonna lose that hair?
I don't think there's anything that can make him lose it.
Enough on his body though.
Looks permanent.
Yeah.
He goes to transplant, we'll have his hair though.
We didn't lose his until the transplant.
Usually it doesn't. Until the
Yep.
transplant.
I just wanted to say thank you, Dr. Uberti. You did my transplant 11 years ago, and I was in remission for almost 7 years.
Last year.
So thank you.
I don't remember you, but I don't remember my patient. Don't feel insulted.
We have a little more time if anybody has a question either on here or in here. It's nice to chat like this, just, anything that you feel like asking or talking to other patients about even, because it's a good opportunity since we're all kind of hanging out here.
I have never heard of this myeloma before, and I've talked to about 20 people in the last 2 weeks that have it. Has it increased in?
So it hasn't increased, but because we're doing so well with myeloma, there's a lot of people who are alive with myeloma that we've ever had before. So the percentage of people getting it aren't increasing, but the percentage of people who are alive and have it are increasing. So that's why it seems like everybody has myeloma. That's what happened. Yeah. And plus, when you get involved in myeloma support groups and all that, they put you in touch with other people.
Right.
And once you have it, other people say, hey, I've gotten that, or my friend has that, or my brother or uncle or mother has that as well. So it's not an uncommon disease. It's as we age, the median age of people with myeloma right now is about 69. So it's a disease that develops as we age, as most cancers are. As we live our lives, we go on to develop genetic mutations that sometimes cause nothing, but sometimes if they occur in certain parts of our genome, they'll cause us to get cancers. So people always ask me what causes cancer. It's part of growing old. Our DNA is constantly bombarded by our environment, our aging process. There's just haphazard DNA changes that occur in DNA. And when they involve other mechanisms that tell our cells to stop dividing, and we lose that ability to stop our cells from dividing, that's what causes cancer. So if I could use Terry as an example, his B lymphocytes have gotten some genetic mutations that have caused them to proliferate like crazy. Usually all our cells stop dividing at a certain point. When you develop a cancer, your cells start dividing like crazy. So it invades organs, it's invaded his bones, it's causing damage for sometimes to his kidneys, other organs. So we have to stop those cells from dividing. And that's what all the chemotherapy given does.
Come a long way, though.
We've come a long way.
Last 15 years,
We've come a tremendously long way. I mean, Sid, how long have you had myeloma?
50,
15 years.
60.
That we know,
Yeah.
probably 2 years before that.
Jeff thinks it's probably another 3 years.
Yeah.
Yeah. With
Do
all
you
kinds of,
do you do any allogeneic transplants at Carmanos?
So we do a lot of allogeneic transplants, not so much for multiple myeloma anymore. We used to do a bit more in the past, but the therapy has been so good with other agents. And the problem with allogeneic transplant, it is a tough transplant to go through. You know, compared to an autologous transplant for myeloma, we'll use the patient's own cells. That other transplant is very tough, very tough. I'm not sure it really, even though we have, it's not something we routinely recommend anymore because the therapy for myeloma has become so much more effective.
There was a trial that was done in Washington State at the Fred Hutchinson Cancer Center of a autologous transplant followed by a mini allo transplant. Do you know anything about the results?
Yes, I do. So the results didn't show a benefit into doing that type of the auto transplant followed by an allo transplant. There was some suggestion that the patients who had the allo transplant didn't relapse as much. So it is probably effective therapy against myeloma, but the toxicity of it was a little more than we'd like. So whatever we gained in not relapsing from the myeloma, we lost in patients dying from the toxicity of the transplant. So that was an old trial. It was reported on several years ago. It showed some promise in the allogeneic transplant, but the toxicity just made it too difficult to continue with that unless we do an investigational trial on it. So again, the other agents for myeloma become so much more effective right now. We just like the easy way of treating it right now that doesn't cause the patient too much discomfort, doesn't require hospitalizations, and is usually well tolerated as an outpatient.
Are the stem cells that you harvest and may use in the future as effective as the first one?
They are. So we transplanted patients with stem cells that have been frozen for 12 years, and they work just as well.
How many trials do you have to fail before you would consider going back and trying an autologous stem cell transplant again with harvested cells?
Say that again. I didn't quite catch your question.
How many therapy failures, how many lines of therapy would you have to fail before you would be considered for an autologous stem cell transplant, a second one with stored stem cells?
Look at is how long the first transplant lasted. So if the first transplant lasted, let's just say 10 years, which I've seen it happen, and the patients relapsed after that, then we would recommend a second autologous transplant as soon as the patient relapsed and goes through some therapy. If the transplant lasts only 18 months, let's just say, we don't think it's worthwhile to go through a second transplant because it's just the risk of the transplant don't outweigh the benefit you get from it. So a lot of how we make that decision is how long the first transplant lasted for.
And what's the typical cutoff for deciding it's lasted long enough?
18 months. And that's just a number we decided is a good number to use. We've done it a couple times for different reasons in patients who relapse very early. but those are unique circumstances. So sometimes patients don't have their cell count as low and can't get their cell count up. Sometimes we do a second transplant just to get their cell count up a little bit better. But that's an unusual circumstance. So usually our cutoff is about 18 months.
Some doctors are saying now that even if you've had your first remission lasts 5 years after transplant, that there's still so many new good therapies out there other than the stem cell transplant that it makes sense to do those instead.
I mean, certainly that is an option. I mean, we make the recommendation to consider a transplant at that point, but there is good other therapy you can try, certainly.
But if it were your patient, then most of your patients, if they've had at least 18 months of remission and then relapse, you'd consider the stem cell transplant again if they've got stored stem cells.
Again, there are, as you said, there are a lot of good therapies that may be equally effective as a second transplant, but it is an option. You know, the reason a transplant works is because we use a different type of targeted therapy against the myeloma cell. We use a drug called melphalan, and it kills off myeloma cells by a different mechanism than the standard therapy we give for multiple myeloma. So that's one of the advantages of doing it, because your cancer cells learn to become resistant to all the standard therapy we give. And by giving a new type of therapy that kills off the myeloma cells by a different mechanism, you avoid that resistance that cancer cells develop over time. And sometimes you can overcome that with the melphalan we use for transplant. So we try to take that all into account. And if some patient tells me it was the most miserable time I had in my life and during the transplant hospitalization, which is about 14 days, I'm not going to recommend another transplant on them if I have another good therapy for it. You know, we want to keep you as outpatients. We want to keep you functional. We want to do the best for you in terms of keeping the disease under control, but making sure you don't have undue consequences with whatever we try to treat you with.
Okay, thanks.
I have a question. I had my stem cell transplant in 1999. And my question is about, when do you call it a relapse? You know, after a couple of years, my IgA was climbing every month. It was going up every month. And my oncologist at that time chose not to treat it again. Of course, in 2001, there just wasn't any treatments available. And when I did start treatment, it was when my IgA hit 1,000, and the only treatment that was offered to me at the time was thalidomide, which hadn't been approved by the FDA yet for treating multiple myeloma, but it was approved for treating leprosy. So that's what I got in 2001 was thalidomide. But that period of time, as I was watching my IgA climb every month after month, waiting for my doctor to say it was time to start treatment again, that was a very stressful time for me. So when would you say that relapse started?
It probably started as soon as the IgA was going up. So that was when the relapse started. You know, you have to look at whenever that IgA started going up, that's when you started to relapse. Now, whether or not treatment earlier or later would have been more beneficial, I'm not sure. You know, thalidomide was a hard drug to use. And although we still use it occasionally, now we have Revlimid, which is kind of a cousin of thalidomide, which is much better with little side effects. And Pomalyst is the second cousin of Revlimid, which came from thalidomide. So there's been a progression of better diseases made up from thalidomide. It's such an interesting drug, thalidomide. It was initially used for nausea for pregnant women, and it caused a lot of genetic birth defects. So it's taken off the market. And a patient's wife, saw that there was some data that said thalidomide might be effective in treating multiple myeloma. So she found a way to get it from her husband, and he did very well on the drug. And that's what started the use of thalidomide in multiple myeloma, and eventually led to the development of Revlimid, which is kind of a myeloma cousin without the side effect and better benefit. So it was really an interesting story of how it came back into use, in spite of having such a bad reputation of causing birth defects.
quiet. We have a few more minutes. So if anybody has another question, we can have we're not gonna take too much more of your time because, you know, we allow for an hour and we really thank you for
I'm
taking
sorry I
the
was
whole
late.
hour.
Yeah.
Well, I didn't start it until you got here. But, you know, it's all very interesting and I think that, it's really nice to get different perspectives from different doctors because, every doctor has a different thing that they specialize in and can explain something a little bit differently.
Right.
And so that's very, I don't know, I mean, I'm a lay person when it comes to this, but it's very eye-opening to me. I think, and so, so this is an opportunity for anyone, whether you're on the Zoom or here in person, to really just, you got a couple more minutes, so ask away and then we'll be done.
You know, and we do subspecialize. Some doctors just treat myeloma, as you know, some doctors do stem cell transplant for myeloma, some doctors do CAR T cells for myeloma. So different doctors have different subspecialties in the treatment of this disease. And some doctors treat a lot of different diseases along with myeloma. So it runs the gamut of how physicians practice. And everybody feels they're absolutely right and absolutely know the right way to treat.
Well, I think that what I see though is different ways that things are explained,
Yeah.
which I think is really beneficial because I think that it's easier to understand if you hear it both ways.
You're absolutely right.
So, anybody else got a question?
All of our doctors seem to have their difference of opinion, but when they get on that panel at Wine and Dine, there's a lot of agreement and a lot of give and take. So we love to see that.
Okay.
We're looking forward to that in September again.
Then we go back, we start arguing with each other again.
We all learn that way, right?
That's fair.
Well,
Thank you again.
thank you so much for. And we also really appreciate our sponsors for this event. I usually try and grab my sign, so everybody knows I'm talking about, but I did send it out to everybody else. So we thank you all for being here and for doing this because we could not have these if we didn't have some sponsors that came to them. And more importantly, we thank Anthony for you guys on the Zoom. We had a really good one. All right, well.
Thank you, everyone.
Well,
Thank you.
and we'll take care, everybody on the Zoom. I'm gonna end it now. See you. Ellen, I love your art.
Oh, thank you. Thank you. Thanks, Dr. Uberti. Really appreciate it.
Yeah, man. Visiting my grandchild, my